So I want to talk about some, first of all, very importantly, are the barriers to therapy, and then we'll talk about some solutions and resources for patients. So the two most important and common barriers to therapy that I encounter every single day when I see patients, I mean every single day, are patient and, very importantly, physician acceptance of the medicines we're going to use, and also the dreaded insurance world. So IBD is unlike cancer. So in cancer, mortality is a major concern, and therefore patients will pretty much they'll jump off a bridge if it means that they'll save their lives. They'll do anything, no matter how toxic. And IBD, since it's not fatal for the most part, thankfully, physicians and patients tend to really focus on just the risks of the medicines, and they forget to look at the risks of the disease, and what they really are most sort of fearful of is cancer and potentially the need for lifelong therapy. But when you ignore the risks of disease, this is what happens. This is nationwide biologic utilization. This is data from Market Scan and Medicare that Corey Siegel presented at this year's ECHO meeting. And this is using Sankey diagrams. So Sankey diagrams are flow diagrams. They were initially actually developed to describe the flow of like a steam engine. Sankey was an Irish boat captain. But actually, they were even used before Sankey by a Frenchman named Charles Minard to describe Napoleon's geographical flow through Russia in 1812. So in Sankey diagrams, the width of the arrow or the box is proportional to how much stuff is going on there. So if you see initial therapy, so these are the first three sort of courses of treatment for patients. And if you see initial therapy for Crohn's disease, 82% of patients are treated with either corticosteroids and or 5-ASAs. Only 5%, less than 5% are started on a biologic. That's really terrible. In fact, 63 of patients initially started on corticosteroids were only managed by this agent, and some up to 10 cycles, which is like really horrifying. And when we look at overall biologic utilization in this data set, in Crohn's disease, it's still less than 20% nationwide for Crohn's disease, and a disease that progresses in almost 90% of patients. That's a huge disconnect. These data are like hugely alarming. And in UC is even worse. Less than 1% of patients initiated biologic in ulcerative colitis, and overall only 6% use a biologic in ulcerative colitis. And if you start patients on 5-ASA therapy, it takes them a year and a third before they really even start thinking about getting on biologics. So this is a really important data. So now let's talk about the insurance problem. So first of all, you need insurance, right? Lack of insurance leads to lack of medications, lack of tests, lack of office evaluations, and flares and worse stuff, such as hospitalization, complications, surgery, and maybe even cancer if they're not getting surveillance. So I just want to review a few kind of nuts and bolts topics in insurance, some definitions, a little bit about the Affordable Care Act, Medicare and Medicaid, some special considerations, and choice of drugs. So uninsured means no insurance of any kind. Underinsured means insured all year but not enough, which include, and some more specific definitions might be medical expenses more than 10% of annual income less than 200% of the federal poverty line, and medical expenses greater than 5% of annual income, and deductibles greater than 5% of annual income. These people are likely to be underinsured. And also this concept of cost sharing, which means that insurance companies are having the patient pay more of the bills, and sort of three kind of very common types of cost sharing are the deductible, which is the amount you pay before your insurance starts to pay, co-insurance, which is actually your share of the health care costs, and a copay, the amount you pay for each service. So before the Affordable Care Act, and this is important, for instance, in 2012, for people aged less than 65-year-old in America, 47 million people were uninsured and 32 million people were underinsured, which leads to 79 million people with inadequate insurance. And by state, Adams State and Massachusetts was the best, 4% uninsured, and then Texas and Nevada were the worst at 20% uninsured. And for the combination of uninsured and underinsured, it was a low of 14% in Massachusetts in 2012, and 36 to 38% in these following 5 states listed there. So why is there a lack of insurance for patients? Well, some have limited income, certain demographic factors like ethnicity, geographical location, education, employment, underemployment, and unemployment. Underemployment is really important. When they report unemployment statistics and say they're going down, you know, really you're not looking at underemployment, and you're not looking at the people who've just given up looking for a job and therefore not captured by these statistics. So it's very important. Some employers don't provide health care benefits, and then this cost sharing thing. Patients are paying more and more of these costs as the insurance companies are getting richer and richer. And young people often feel like, well, I'm not going to get sick, so I'm not going to get insurance and waste my money on that. I'd rather spend my money on beer, which might be a reasonable assumption. So a few really positive aspects of the Affordable Care Act. I'm not a politician. I don't know what's going to happen in the future. But it did some good things and made some good efforts to require most people to have health insurance, to require employers to cover for especially large businesses with more than 200 employees to offer coverage to all, to expand Medicaid and Medicare type of coverage, expand funding for the Children's Health Insurance Program, and to really give patients help with this cost sharing by giving them some subsidies. And very importantly for our patients, this no pre-existing clause, and also no pre-existing condition clause, and a no lifetime limit on certain coverages. I want to just review a few little details about Medicare and Medicaid. Remember, Medicare is a federal program. Medicaid is a combination of a federal and state program, which is run by the state. For eligibility for Medicare, age 65 or up, and also disability. So if you have Lou Gehrig's disease, ALS, you get immediate qualification. If you have end-stage renal disease, you get it 3 months after a transplant or initiating dialysis. And very importantly for our patients, if you're on disability for 2 years or longer, you actually qualify for Medicare even if you're like 18 years old. For Medicaid, eligibility is determined by a combination of both income and categorical factors. So it's mandated for patients with a very low income, pediatric or pregnant patients with a very low income, and most disabled or older patients who are collecting SSI cash assistance. As far as the Medicare Parts, Part A is inpatient services. Part B is outpatient services, which includes certain drugs which are infused or injected by the physician, and nutritional therapy, enteral and total parenteral nutrition, as well as supplies for these, and ostomy supplies. And also Part B covers certain vaccines, including the flu, pneumovax, and hepatitis B. Part C is also called Medicare Advantage. It's run by a private insurance company like an HMO or PPO. And Part D covers all the drugs that aren't covered by Part D, which includes the self-injectables that people can do at home, and the Zostavax, for instance. So what's this dreaded donut hole people speak of? Well, it turns out that most Medicare prescription drug programs have a coverage gap, which is a temporary limit on coverage. And in 2017, that begins when you spend $3,700 out of pocket and ends either on January 1st of next year or when you spend nearly $5,000 out of pocket, at which point you have what's called catastrophic coverage for the rest of the year, which involves only a small copay or coinsurance. And things that count towards the donut hole are your deductible, copay, coinsurance, and 50% manufacturer discount on brand name drugs. Things that don't count toward the deductible are toward your donut hole are your premium and pharmacy dispensing fee. And under the Affordable Care Act in 2017, you pay 40% for brand name drugs and 51% for generic drugs in the donut hole. Now let's talk about some special considerations which I encounter very frequently, I'd say probably every week. In my practice, age 26, before the Affordable Care Act, insurance companies could chuck you when you were 19, but now they have to cover you up to age 26. Even if you're married, living or financially independent of your parents, if you're in school or eligible for your employer's plan, they still have to cover you. Also, things that come to plague people are the end of year when plans renew or change. It often starts in October, and loss of insurance or job, and we'll talk about some solutions for these. So how about choice of drugs? Well, it turns out that choice is not always up to us. Some plans dictate that certain meds must be failed, for instance, 5-ASAs and or immunomodulators in order to prescribe anti-TNF therapy. Some plans dictate which biologic class must be tried first, and some plans dictate which anti-TNF within that class must be tried first. And to illustrate this point, this is a very interesting recent study out of Adams Institution by one of his colleagues, showing that they looked at the National Association of Insurance Companies, a report of the top 125 insurance companies by market share in 2014. And they looked at the top 50 of these, the first 50 which had online policies regarding the use of anti-TNF therapy or vedolizumab. And what they found is that only 10% of insurance companies allowed you to start an anti-TNF therapy first in Crohn's disease, and only 2% in ulcerative colitis. Most of them require that you fail 1 or 2 anti-TNF drugs before you can prescribe an anti-TNF drug. Most of them also don't allow you to start vedolizumab without failing anti-TNF therapy, and many even require you fail 2 or more anti-TNFs before trying vedolizumab, which in the case if you have a primary non-responder with adequate levels is completely insane because you're not going to respond to the next anti-TNF therapy. Most of them don't have a policy for ustekinumab as of that time, and most of them prefer infliximab over adalimumab for both Crohn's disease and ulcerative colitis. And most shockingly, only 10% of the insurance company plans adhere to the AGA guidelines for the treatment of Crohn's disease, and only 2% adhere to the AGA guidelines for the treatment of ulcerative colitis. So this is really horrible stuff, guys. So let's talk about some solutions and resources for patients. So breaking the habit, some insurance-specific solutions, physician persistence, charitable organizations, and pharma. So remember, fear the disease. The risk of the disease is much worse than the risk of the medication. I showed this slide already. Crohn's disease progresses in almost 90% of patients. And what are patients most worried about? Well, the risk of cancer. And here are some data on anti-TNF monotherapy and the risks of overall cancers. No risk of overall cancers in these 3 studies here. How about the risk of non-melanoma skin cancer? Mixed results, so maybe, if anything, maybe a small increased risk of non-melanoma skin cancer. And for ustekinumab, we have data from SOLAR registry in psoriasis showing that ustekinumab is associated with numerically lower risks of cancer than infliximab or other biologics. So these drugs are safe. This is maybe the most important slide of anything I'm going to say. The pyramid is dead, people. Get rid of this. There's no step-up therapy. This is garbage. Don't ever do this anymore. This is not the way we do stuff anymore. Biologics are safer, likely more effective than immunomodulators, although they haven't been tested in comparison for ustekinumab or vedolizumab like we did with Sonic. They're probably going to be more effective than the immunomodulators. So use them first for moderate to severe disease. These are more specific, more intelligent therapies for people and safer. And also risk stratify. Use appropriate aggressive therapy, including combination therapy. Sometimes I do use still combination therapy and not optimize monotherapy in my sicker patients and get better outcomes. And treat earlier, as we've seen, to improve long-term outcomes and minimize the risk of our most dangerous medication, which is corticosteroids. So let's talk about some basic insurance problem solutions. So as I mentioned, you guys need, patients need insurance, and they don't always sort of get that. So whether through work, family, the Affordable Care Act, or Medicare, my younger patients just think that Medicare is for quote-unquote old people. But if you're on disability for 2 years, like I mentioned, it's a great solution. Age 26. Most people, fortunately, know when they're about to turn 26, so that's a good thing. So we can plan ahead with student insurance, private insurance, Medicaid, catastrophic coverage. Also, most people know when the end of the year is. December 31st happens at a predictable time every year. So patients who consumed a lot of your time with authorization and denial issues need to consider better plans. These often cost more, but they get better coverage. And loss of insurance and job, actually people often know when this is about to happen, and if we plan ahead, we can actually help them out and get things going. So I just want to just briefly mention the Affordable Care Act plan. So people with IBD who are going to have a tremendous health care burden, very expensive, they shouldn't be doing the bronze plan. Even though they have a lower premium, they're going to be paying more over time or throughout the year. So that actually is going to be worse for them. They should really consider silver or gold plans. For Medicare, if they have Medicare, but if it's not covering enough stuff, there's something called Medigap, which is Medicare supplemental insurance, which is sold by a private company, so you pay a premium. It covers a cost that Medicare doesn't cover. You have to have Part A and B for Medicare to have this, and it does cover some drug stuff. So I think by far the most important and best resource for patients is the treating physician. So payers are often obstructive and a time drain. So use your nurses and medical assistants to really help send extra documentation, do the appeals, follow up on the appeals, make sure these companies are being held accountable and this stuff is happening so you can find out if your drug is approved or not, and if not, you can do something about it. The insurers, they know, the payers know that the doctor's time is often the weakest link, and they're going to exploit that to their financial benefit. So don't give up. You can beat them. As my wife always says, persistence beats resistance. So back in the day when guys were trying to ask her out, if they just kept asking and asking and asking, eventually she just broke down and said, all right, let's go out. And then it wouldn't last very long. But again, there is something about fatiguing the enemy by just being so annoying that they're like, this guy's like a pain in the ass, we just gotta get rid of him. So you need to, right, yeah, she actually asked me out, so anyway. But you have to write letters to get what you need. And do peer-to-peers. Call the medical director. Defeat them with data and expertise. Remind them of the financial consequences of them not helping you out. Hospitalization, surgery, that's going to cost them a lot of dollars. They're not going to like that. And also, I'm a little bit, less enthusiastic to admit this, but you got to make them squirm. You got to put them in your place. What if, you have to tell them, what if this patient were your child or your mom or you? Wouldn't you want the best therapy for them? You got to hit them below the belt and just do what you have to do to help your patient out. Maybe lie. You got to do what you got to do. So I didn't say that, but anyway. So letters that I often write for patients, they do with two important topics. One is the use of medication. So sometimes the use of biologics early or first. Or the choice of your first biologic. Sometimes you have a very specific reason. Maybe you want to use Veto. Maybe you want to use ustekinumab. Maybe you want to use a certain TNF agent. Maybe you want to use infliximab for UC. Certain conditions, and you have to often justify that, but you can write these form letters that have this sort of documentation. Biologic dose escalation, this is a common thing that we write letters on all the time. Biologic TDM, they're often reluctant to give you more drug just because the drug level is low. And off-label use for biologics, which we have to do creative things for patients that are sicker in some of our centers. And also, they don't love paying for tests for these things, especially TDM for biologics or some of the thiopurine stuff. So in the next two slides, I've given you guys some references that you can use in these letters. So for biologic therapy, earlier first, some randomized study there. So for anti-TNF dose escalation, a lot of studies showing benefit there. For anti-TNF TDM, stuff that Adam's presented already. Off-label use and dose escalation, infliximab for severe UC. Sometimes you have to use escalating doses. There's some data there. Golimumab I sometimes use for Crohn's disease when they've lost response to the other TNFs, but it seems like their pathway is still TNF-driven. For vedolizumab, dose escalation, remember in Gemini 1, patients who didn't respond at week 6 were given the option of having vedolizumab 300 milligrams every 4 weeks. For up to 52 weeks, and 28% of them at the end of 52 weeks were still on drug and responding, so there are some data for that. For ustekinumab dose escalation, there's some data from Remo Paniccione's group in Canada, and then sometimes we have to use, I have some patients on TOFA for UC because they have lost response or failed everything else, and there's the Octave randomized control trials. And there's some data also for thiopurine blood testing that can use. Don't forget that you can also put patients in touch with a hospital, get them in touch with a social worker or financial counselor to help them gain access. Also, your business administrator and pharmacy head can be helpful to develop payment plans for patients for copay assistance and coverage. They can often even lower the price of the office visit to the Medicare rate. They sometimes can provide bridge funding or cost forgiveness for inpatient services to work with people, because hospitals in general, I think, are more compassionate. If things really get bad, there's always charity. And for these organizations, you have to remember there's a certain well of funds, and it's going to dry up. So early is better. It's first come, first serve. I found this website, Needy Meds, is a really nice gateway to multiple foundations, including such as the Patient Advocate Foundation, in which for many of these patients need insurance and have to have certain income requirements. There's the Chronic Disease Fund, also known as Good Days, which also helps with transportation and lodging. There's the Patient Access Network Foundation, which also covers travel. There's the National Organization for Rare Disorders, which covers IBD. And this one actually also helps patients who are uninsured with various costs, including tests and consultation with a specialist. And there's the Health Welfare Foundation, which is currently closed to IBD, but may reopen in the future for IBD. And then don't forget our friends in pharma. Pharma actually helps patients a lot. There's patient assistance for underinsured. So if you have commercial insurance covering the biologic, they can offer a low or reduced price per dose, whether it's an injection or an infusion. If you have Medicare covering biologic, they can help you gain access to Medicaid, to Medigap or foundation assistance. For those who are completely uninsured, there's also some hope for them. There's some company patient assistance foundations, and also they can help you get access to other foundations. And also, very importantly, they can help patients with injections. They can help streamline the process of getting sort of through the whole injection process and starting it out. Some of the companies will send a nurse out to help teach patients how to do this stuff, and they'll have an injection, like a nurse hotline for injection problems, whether it's an injection site reaction, or if there's a misfire, patients lose drug, they can actually help replace the drug for them. So there's actually a lot of resources that pharma can help to help use their patients. And I'm exactly at 20 minutes, people. So thank you very much.